this meeting, hence the microphone and the camera. Attendance on the web does not count towards attendance at the meeting, doesn't count towards a quorum, and there's no public statements from the internet. Roll calls. I guess please sign in so we can make sure that your attendance is noted. I received excuses for the meeting for Dr. Josh Kugler, Dr. Kurt Dishner, paramedic Paul Dibber, paramedic James Amelia, paramedic Vincent Papadero, Dr. Alan Shearson, Dr. Bramante, Dr. Matthew Harris. Anybody know of any other excuses or people that aren't in attendance that should be? Okay, moving on. I need a motion to approve the October 2nd minutes and attendance as sent out. Okay. Anybody opposed? Okay, so move. Incoming correspondence, we have a bunch of stuff from the state. Not like last meeting where there's like 10 or so. This time there's only 3 letters. The first one is Stanford Fire Company #1 Incorporated in Stanfordville, New York, surrendering agency code 1330, surrendering their agency certificate for violation of Article 30, 312, Part 1F. EMT Leah Cusino of Staten Island, number 361718, suspended for 1 year, effective 1/11/24. Suspension is stayed, placed on probation for 3 years, effective 1/11/24. Assessed a civil penalty of $2,000, $1,000 of which was stayed, for violation of New York NYCRR Part 800.15B as in Bravo. Last one, EMT Stephanie Lugo from the Bronx, 408783, revoked effective 8/17/22. So yeah, it's a little timely in its delivery to us. It was sent January 23rd of this year for violation of 10 NYCRR Part 800.16A. So if you know of these people and they're in your agency, they've been censured. Moving on down. We received, thank you to Supervisor Jim Amelia from EAB for medical control, provides a monthly diversion report. If you guys want to see that, I could share it with you. It's basically just demonstrates every hospital's diversion request and the reason why they were on diversion and who put them on diversion. There was a brief 10-hour period where due to a high volume and ED volume, call volume, that eBridge was use of eBridge was held, and we reverted back to our radio transmissions. After the evaluation period or the incident action period, we went back to resuming normal operations. I received an incoming phone call from the last meeting actually that's already done. Delete that. Received letters from Dr. Stefan Mulbauer and Dr. John Matthew. Dr. Mulbauer is director of St. Francis, Dr. Matthews at St. Joe's, requesting REMAC membership. At this time, we have no open seats for voting members, so they've been added to the non-voting members list. And with your permission, under new business, there'll be non-voting members in queue for voting positions. For outgoing, there was discussions with Mercy Hospital leadership regarding their continuous psych diversion based on closure of a floor. Mercy was kind enough to do what other hospitals are doing, which is 3-hour reassessments of their psychiatric receiving capability status and update medical control on a 3-hour basis, like all other diversion requests. So those are ingoing, outgoing communications. Is there any other communications that I didn't review? Okay, Chairman Dr. Kugler. So Happy New Year to everybody. Welcome to our new members, voting and non-voting. I'm very happy to have you here. And again, once again, thank you to those who were here and left due to work obligations. Let's see. That's really it. I just want to say I hope we have a great, successful year. This is the start of a new term for all the members. So let's try and make our attendance, please, and join a committee if you can. Moving on to reports, CMAC. There was no CMAC meeting. It's coming up next week. For QAQI, Dr. Zazzo.
Hi, good afternoon, everybody. A couple things. First, I want to thank Dr. Newberg. We talked about instituting now a review of all cardiac arrests in the county. Dr. Newberg, with great effort, put together a sort of a point and click kind of survey form that we'll be able to do. It's going to de-identify any of the agencies, so there's nothing punitive. This is more to pull information in, see what trends are, and then we can we'll know who is who on our side. If there are any trends that need to be corrected as far as transporting non-viable individuals, we'll work on that and to look at all aspects of it. So I want to thank him for all the work he did on that, and we'll be beginning that shortly. Hopefully by the next meeting, we'll start introducing that. You'll get an agency code that'll be, a de-identified code, and keep you anonymous. And again, not to be punitive, just to get the trends and see where we are. The second bigger issue, we had a report made to the QAQI committee, known agency, that had an airway issue. Basically, as coming as a second in motion, what's going to happen now is any advanced airway placed is going to be owned by the person that places the advanced airway, all right? And that person will be responsible for transport and monitoring. We're just trying to avoid having sort of the drop-in play, do a procedure, and then drop out and leave it to the other, to the agency on site. So that's being brought forward. With that, again, patient care is paramount on this. Is why we're doing this, and we just want to make sure that we are following protocol and keeping that in line. Any questions on either of those two? Okay, moving on.
Sorry.
No problem.
All right, thank you. Any questions for Dr. Zazzo? Fantastic. I'm going to add in, we're going to start a field physician QAQI, eBridge QAQI, stroke and STEMI QAQI, in addition to airway QAQI. So Dr. Zazzo is going to have a lot of different topics to look at. And so we're going to need a lot of help, people to look at each particular item. One of the things, just tagging on to your discussion about cardiac arrest, is hopefully we can become a CARES registry region. That involves significant cooperation with our hospital partners. I think this makes the hospitals look good too. So that's something with Dana. Where are you? Thank you. So we're going to need your help getting our hospital partners involved, because CARES requires follow-up and the outcomes. So moving on, airway / RSI / iGel / anything that has to do with breathing.
Okay. So we had both an RSI and a BLS iGel use. So we had the first of both. So that in the first month of the year. So that's good. From the iGel side, there was a BLS provider that placed an iGel on a cardiac arrest with ALS providers. They needed a rescue airway, and the BLS provider provided the rescue airway in Glencoe. We reviewed it from the committee. Everything looked good, and we're going to submit that up to Hudson Valley. So that was the first BLS iGel use in Nassau County. We did get messages back from Hudson Valley. They're very appreciative of what we've been doing. They asked that all the agencies involved, just making sure that they're documenting properly and keeping them updated. So just do that through us, through me and Don and Scott, and we'll make sure that we coordinate with Hudson Valley. Any use of it, they have an online form. It's like a Drupal form, they call it, but it's basically a state form that you fill out if there's a use, so that way they can track them. They want to make sure that we have it properly documented on the PCR. We're also reviewing that with Dr. Zazzo and myself, so we'll make sure that goes up through there. So far in the state, there have been 150 uses of the BLS iGel since the start of the pilot. There are 80 approved agencies, of which 17 are in Nassau, and there's 1,000 EMTs trained, of which about 200 are ours. So we're doing very well in representing in the the research, and they said that right now it appears that the use of it by EMTs has been successful and they have not run into any major issues. Their major issue is just the data collection, so that's why they're just asking that we make sure we coordinate that with them. So we'll continue to monitor that from the airway committee, but that looks good. From the RSI side, we had 18 members come to the RSI committee meeting prior to this. We had a quorum, we had everyone there. Couple things, we reviewed that RSI use in New Hyde Park. It was basically a peri-arrest and probably a stroke patient that wasn't protecting their airway. Everyone agreed that the care was proper. It was handled and reviewed through QA the way we're supposed to handle it. So first case out of the way and everything looked good. And we're gonna probably have a second RSI medic, but we had to wait to table it until the next meeting because the medical director from New Hyde Park was unavailable today. So we are making the standard that when agencies bring providers to us to be RSI providers, we want the physician to come and vouch for them and talk to us and make sure that the physician is engaging us with the committee. So that way we know the physician's engaging the medics in the field, and that way we have direct communication while we're kind of growing the program. We're going to be developing, so everyone that's going to be an RSI medic has to have the difficult airway class. That is a standardized class that is being held by various educational providers. But then we also have our own credentialing class, and we're going to be developing our own regional credentialing class through the FPA. A couple of the members of our committee that are involved with teaching from Northwell and Suffolk County and from a couple agencies are going to help us, and we're going to develop that in conjunction with Don and Scott over at the FPA. So we're going to have our own. Once we get this done, we'll have our own, and NUMIC was coming in and have a couple other folks helping too. So we'll have our own course for the county, and then once we have that approved, hopefully by the next REMAC meeting, we can go live with that, and that way we can start credentialing providers a little bit quicker. In the meantime, there's a provider waiting for Glen Cove, and we're going to try to get them credentialed in Suffolk County in the meantime, so that way that person can get trained. But then once we have the Nassau County course up and running, that should be much better. We have the seconded motion. Want me just to bring that with a new business, Dave? The motion that we're going to bring with the airway stuff.
Yeah, you could just say you have some stuff for.
Okay, so we basically we have a motion with three parts that we want to bring up during new business. The part about if you intubate the patient that you have to stay with the patient. We want to readopt the confirmation of all advanced airways at the hospital. So we're adapting the form, the regional form. So this is not just RSIs, it's RSIs, MFIs, supraglottic airways, any advanced airway, BLS it up. So that way we're treating all the airways the same. That was actually our friends from NUMIC's idea, and that was a really good idea. So that we basically treat all airways the same, and that we review all of them through the RSI and airway committee. So that'll be MFIs will then get reviewed also with the RSIs. So that's we'll have that as a seconded motion coming up for new business. But basically we want to make sure that now that we have this robust committee, that since we're engaged, we're making sure we're doing the right airway procedures, that we are reviewing them properly, and then obviously coordinating with Dr. Zazzo for anything that we need to coordinate with QA. Also, is Dr. Bramante here somewhere?
He's not.
Okay, Dr. Bramante from the Policies and Procedures Committee knew that we were doing that and said that whatever we developed from the Airway Committee that he was okay with it from the Policies and Procedures side. So we coordinate that with them for when that goes. And I believe that should be it. Thank you, everybody. Thank you for everything. And the engagement, by the way, has been awesome, and we're making really good progress, and we really appreciate that. Anyone else that wants to help, please, join. We're very excited about this. We're building a really robust system now, and that's really good.
Thank you. That was awesome. Moving down the list, protocols, Dr. Ryan.
Yeah, no meeting.
Okay,
no
fantastic. So just a heads up, hopefully in February, the version 24 of the New York State ALS protocols will be approved at the CEMAC if we have a meeting. Last meeting, we were supposed to approve it, but they didn't have a quorum, so they couldn't hold any official business. So coming forward, that should be soon. So please keep an eye out and refresh your screens after February. Moving on to credentials. This used to be one of the biggest, most contentious parts of this meeting every January. Happy to say that once again, we've got 100% agency compliance with medical direct affiliation forms before the deadline. Nobody needs to be suspended. Nobody needs to be downgraded. I was actually dreading this, and then Don presented the the completed list. So thank you to all of the physicians and the agency leaders for getting that documentation in place, helping to keep our region up and running. There was a series of letters sent out to members of this committee seeking their interest in maintaining membership at the end of the year. For anybody who missed 1 or 2 meetings a year, everybody that had received a letter has indicated that they wish to remain on the committee. So thank you for staying. Please make sure you come, because we can't do stuff with you when you're not here. Let's see. Is there anything else that we need to adjust for credentials? Just the membership attendance. We have the 2 new voting members, and we have 2 new non-voting members that we'll have to bring up under new business. Under policy, Doctors Bramante and Dishner are both excused. We have the policies brought forth for RSI that we'll bring up under new business. RTAC, Don, did you want to speak about that?
Yes, so thank you. We had a chance to be invited and attend the last virtual RTAC meeting. They, like many other places, are going through some reorganization, sort of a fresh start for the new year. They did have some asks for the trauma form for the e-bridge, which is one of the handouts that's going around. So I guess you want to tackle that on the new business. But anyone working in a trauma center or trauma coordinator knows that EMS, under the accreditation and questions asked when you audited, to play a key role. So they were very happy to have somebody involved and look for a brighter future ahead.
All right, so moving down to e-bridge, my brother was excused. So basically, as you saw the handout, we're making some additional changes to e-bridge, which are going to incorporate the recommendations from the RTAC. We have to be good partners, and it also helps the receiving trauma center know what they're getting, to know if they need to activate the trauma team or not. So we get a lot of issues, a lot of complaints where, well, I called for a trauma team, but the trauma service didn't get a set of vitals. They don't know a mechanism of injury. They don't know your ETA. They don't know that stuff. If you fill out the trauma e-bridge form correctly, they'll have all that, and they'll be able to determine what level of trauma activation you need based on what you've provided. It was also brought to my attention, just as an aside, going back to RTAC, that every facility has their own trauma response. And while you would, as a pre-hospital provider, may be expecting everybody and the hospital administration to be there. I don't know if anybody saw Monty Python. The administrator's coming, so we have a machine that goes bing, right? So the machine that goes bing may not be there when you make a request, but the ED staff will make an assessment and determine what level of trauma to activate up to. So don't be disappointed, but if you're finding that you're making multiple trauma requests and you're not getting met, then it needs to be escalated. But start with the receiving facility and ask the question why. It could be that they're already doing a trauma and they're in the room next door. They just didn't come over to your room. So we always need to look at our partners and work together.
Doctor.
Yeah, Ernie.
So I'm trying to understand this. Is this information going to have to be input into eBridge before the notification is sent?
I don't know if,
Yeah, so
okay.
When we started eBridge in its infancy, right, baby steps, we all
Right.
remember a few months back, none of the forms have any required fields in them.
Right.
The system already knows who you are and where you're going because you've selected it that far in order to get to one of the forms, whether it's ALS, BLS notification, trauma, stroke, or anything else. Specific to the specific to the trauma form, RTAC's asking, commensurate with, we need a little bit more information in order to properly pull the trigger on teams based on our internal, processes. They're asking that we implement mandatory age, whatever's listed, age, blood pressure, heart rate, 4 traumas. So unless.
Is that what yes?
What's that?
You're just saying yes. And he asked you a question. Do you need to put these things in? The answer is yes.
Yes,
So-
but again, that's a change, and I want it to be clear and discussed here if anyone has misgivings about that.
So the only misgiving I can see is that while we did have the opportunity, if we were really busy in the acute patient, we could hit the trauma note and get back to them later on. Now we can't give that trauma note until that other date is put in. That may create some problems. That's all I'm suggesting.
Well, and the ask of our in-hospital compatriots and trauma specifically in this regard is that earlier is better. And I know that that's not always been made clear here or sort of been made required here. So there's an opportunity to implement that early on. And granted that, you know, it's 3 additional button clicks, but you were giving that information via radio anyway. So it's the same amount of information, just in a different format, if you will.
So. Button clicks plus the data entry, but the thing is also, when we said this, it was that but when you get there, they're gonna be re-triaged again. So.
Of course,
Well, I mean, and that's certainly that's their prerogative. I'm not,
Right.
not arguing that. Just bit of information. It's gonna make it difficult. to
So
for a
one of the
skilled
other
provider.
changes in the future that's happening to eBridge, it's not available right now, is the import of your PCR monitor data into the software. It's not available just yet because we're such a diaspora in terms of systems, but that is an up and coming thing, and that's less information you need to put in. But right now we need to stop, and the ask is also to enter the data and hit send before you leave the scene. Because you may be with a trauma patient that needs a special service, medical control will know that that service isn't available to where you're intending to go, and they'll reach back out to you rather than getting on the radio or hitting send when you're en route and you're at the back door of the receiving facility. At that point, there's no redirection. There's not, you have no chance of taking the patient if you're in between 2 trauma centers to the other one. However that may go. So we're asking you notify and make your hit send before you leave the scene.
Yeah, I mean, Ernie, I can say a recent case at South Nassau, we got a notification with a picture that the medic was actually being awesome and sent us a picture, but unfortunately the angle of the picture wasn't quite as clear as the medic thought about a rapidly expanding hematoma and someone that fell, and they didn't give us vital signs. So I have a picture, but I didn't understand the picture because it was out of context and I didn't get vital signs. So I couldn't activate a trauma because I didn't understand that it was a trauma. The minute they got to the door, they were 70 over 40 in the field and this thing was huge and it was obvious. And then they said, well, why didn't you activate? And I said, well, I didn't have the information I needed, even though you thought I provided the information. So I mean, I think very basic information like that makes a huge difference because any hypotension in the field is trauma alert. So if you get 1 hypotensive blood pressure, we're trauma alerting that. But if you don't have that information, then it unfortunately, and then the EMS just gets frustrated because of why you're re-triaging. Well, I didn't have the information. So
Right.
I think there's gotta be a balance there in basic stuff that makes it easier on all of us. So.
I think from
Chairman
the same perspective, once again, through eBridge, one of the things we brought up was it will also help us with QA, QI on a system-wide basis and stuff to be able to gather the information, which is the information that we haven't been able to gather either via radio or via telephone in the past. So for quality assurance purposes and stuff with the different servers and stuff, we can mitigate any issues and stuff and be able to use quality improvement stuff system-wide to be able to manage the strokes, traumas, as well as cardiovascular issues and stuff.
Thank you. And it's like you almost read my mind as to what I was going to say next, which is the advanced airway form is going to be moved to eBridge as well. So the providers are going to have to use that tool to send and have the doctor sign off on any advanced airway, which will be discussed under new business. Let's just see, moving down the agenda, policy, eBridge. So the Nassau redesign tag. Nothing. Yeah,
The spinning wheel.
spinning wheel.
Yeah.
Okay. Updating.
Updating, I guess.
All right.
I think we're still waiting to hear back from the county.
Okay.
Yeah.
Yeah.
How many of you guys have gotten a notification of a STEMI via eBridge EKG sent? I've gotten one so far. And, I just wanted to know, how difficult is it for you guys to do that in the field, to actually send that? Is anybody calling a STEMI based on that with the history of having chest pain or a chest pain equivalent yet at any of your sites?
So I'm only seeing the notification at my shop. I haven't done a query on the server to see if there's been attachments. But you can't notify or activate the cath lab if you don't have a EKG.
I've got one that came over pretty well on that. I just wanted to know, what is
I
our,
mean, I think
EMS
at this point,
wherever
you
they
have
are.
a picture of it, right?
Yes.
That's right,
Definitely.
yeah. But medical control is still sending over the transmitted EKGs, right?
If they send it to us.
Yeah.
very rarely,
we send it.
But it has to be sent.
Yeah.
But the best way to do it is on eBridge, because on the hospital side, the eBridge has two parts to it. On the hospital side, the receiving facility can then activate via eBridge the cath team or the stroke team or the trauma team by just forwarding that information. So now the cath attending gets the pre-hospital EKG and the patient demographics. He doesn't even need to go to the ER to meet the patient. He can go up to the cath lab, or she can go up to the cath lab. The patient gets registered and boop, right upstairs.
you can save 20, 30 minutes
Right.
and save a life.
So
Yeah.
We trust you guys, you know,
Yeah.
that's the thing, if you
But
guys
it
get
has to be
comfortable
done.
with this, send this information. Hospitals can really do a lot with a 20-minute save, especially when it's past that 5 p.m. when those cap guys are gone and the nurse is gone. So it's something we should consider just advancing, get to the place where Rochester and a couple of other places where they do this pre-hospital. Where we should
Just
be.
1 second. Yeah, done.
No, thank you. So when we unveiled eBridge, it was to fix some of the things that we knew was going on, and we need to we're gonna step back with the change in eBridge and the updated screens to release some education along with that. Quite honestly, at least in my opinion, from the academy, we haven't always been good in that message that you need to attach 12, right? Especially if you're calling for STEMI activation. That wasn't a consistent message, I don't think, and understandably, it wouldn't then be happening. So, yeah, no, thank you, and
Yeah.
we'll get
We have
better
to
at
search
it.
every hospital, if we have a really good EKG from pre-hospital that looks like a STEMI, is gonna activate off of that, we just have to get the
Yeah.
information.
And to
Yeah.
Don's point, in medical control, I can tell you definitively, if we see a STEMI or we hear them say a STEMI or we see an eBridge of a STEMI, we always query them for an EKG. And we've been recently telling them to send it to eBridge also.
Perfect.
If we get it, we also tell them to send it to eBridge so that they get it double,
Okay,
you know, just to almost test the system out too.
good.
But
Thank
we're
you.
still getting through eBridge, a lot of people, providers who want the reassurance that the ERs are actually receiving it. So, you know, even if it goes acknowledged, there's been a couple serious cases, they pop up on the air, you know, can you confirm that they got this?
Yeah, but if the ER clicks.
I get it, we reassure them,
That's the
but
acknowledgement.
Yeah.
I think it's just the old school still grinding away.
Yeah, Matt,
I have a question for Scott. Scott, in medical control, you still have the capability to receive 12 leads by the LifeNet?
Yep.
So that's still active.
Yeah, there's several agents, I could use one to Levittown, for instance, they have a lot of BLS providers who do 12 leads a lot.
Okay.
And they call a lot, and we review them for them, you know, as per the
Okay.
protocol, and we'll guide them accordingly.
Can that 12 lead now be forwarded to the receiving facility?
We can forward it, yes, we always do, but I always encourage, we've been encouraging them to use eBridge also, so they get familiar with it.
Well, a quick workaround, the doctor was saying, maybe we need to do both. Because all it is a click of a couple of buttons on a LifePak 15 to get that 12 lead out to the receiving facility.
Mhm.
You know, eBridge, you have to take a picture, and I know from firsthand experience, taking the picture with the laptop is not the easiest thing, especially when you got 4 other things to do in the back of the ambulance. So if we can send the 12 lead out, get it out there, get it to the hospital, and then follow up with an eBridge notification, I think we'll be better served very quick.
We've been doing that too, man. Because when you send us a 12 leader Metcom, all 4 positions have this red alert that comes up. You have to cancel it out. So it forces the operator to actually look at it and then send it along. So
I just don't.
Otherwise, it's gonna be flashing at you.
Out there,
Yeah.
where we can do this quick.
Mhm.
And it's to the doctor's point here, that he's absolutely right. When the 12 lead is in your hand, you don't even have to bother question you whether it is or not.
I'll give you two parts to that, but there's one part, and sometimes when it's a very standard, yeah, this looks like a STEM. There's two parts to a STEM. There's history and then there's communication. With the eBridge, you're allowed to do both. That's the only thing. So we'll have cardiologists, some of the guys that are ER guys, we trust them. We know that if we get this information, it's 20 minutes if you get that patient on the table during needle. So this is where we moved. This is a great step that we've taken. eBridge from the first day it came on to now I get 30, 40 of these coming through. We've made great strides. It's now it's time for us to make the next stride. And so even though it takes a second or maybe 5 or 6 more seconds, you're guaranteeing that nurse at 6 o'clock, it's another 20 minutes until when I make that call from the PD versus the 20 minutes that you save by taking those couple of steps and setting it over with patient had chest pain or dizziness, diabetic, or things like that. So,
Right.
I think,
All right, so that's Chuck, we're gonna just move on because
Okay.
we'll go to Chairman Chuck Mackey for the Remsco report.
Thank you, Dr. Cooper. All right, just a couple of quick notes. Once again, thank you to all the agencies who got their paperwork and stuff in. Once again, 100% compliance as of yesterday. I really do appreciate it. Also, I want to thank Dawn for once again compiling a lot of the stats and stuff that were just presented to us earlier today regarding the agency surveys that was sent out. Most of you will see it coming the end of the week and stuff. A lot of good things, a lot of progression and stuff in there. Some issues that once again on a countywide basis and stuff, and an agency basis that once again we can probably do better. And once again, once they come out, you'll be able to review it and see there are some issues and stuff that we need to manage with that. On the regional council level, we have a few seats and stuff that will be coming up for discussion in March. One of them being the Emergency Nurses Association. I've sent multiple emails out starting last September. I've been in contact with their president, who is upstate. To date, as of January, I've got no final documentation or recommendations of emergency nurses in the regional area here that are accepting of the seat. And I've given them till February 1st to provide the documentation and the letter of support for these. So that will be brought to membership at the meeting in March. As you said, RTAC, once again, is restructuring. There's been some changes. Our RTAC representative on the council and stuff has resigned her position over at NYU. And once again, has also resigned from the council. So we're in, once again, talks with the RTAC and stuff as we start to build that relationship back to once again get some representation and stuff for both the REMAC as well as the Remsco. As far as the medical control, I know with Dr. Booten leaving at UMC and stuff, he'll deceive and stuff here. I don't know. We haven't gotten any final confirmation and stuff that's going on, whether there'll be changes and stuff within that seat as well. Involving medical control and NUMC. So we'll let membership once again look into it. Hopefully we'll be able to fix that. The disaster preparedness MCI committee once again is moving along very well. We've once again adopted the plan. The plan has gone through the communications committee. We're looking at some issues and stuff regarding communications, and we're currently in working with training and education as well to develop a plan to roll out the training for the MCI plan to once again get it out to the agencies as well as to the EMS personnel, fire, police, and our dispatchers for that. The state and regional EMS awards applications can be found on the either the BEMS website or once it be placed up on the regional website. We're looking at doing some regional EMS awards this year, not just the state boards. State boards really, once again, are a little bit difficult, once again, on a personal basis. It's a long-term thing throughout the year, whereas we're looking for the regional aspect of the individual pools and the great work that our EMS providers are doing out there. The state awards, we had 2 winners last year out of 10 awards that are given out. And once again, we want to make sure that we get them in. They need to be into the state by July 1st to be considered with that. So April 15th will be the cutoff date, once again, for the committee to once again look at the awards. On the regional side, once again, we'll accept them throughout the year. And once again, be done accordingly, once again, to get those awards and stuff out. As everyone probably knows, the governor has proposed the 24-25 New York State budget. There's multiple new EMS initiatives and stuff out there. In the budget, once again, expanding the definition of EMS, making EMS an essential service, creating EMS zones throughout the state. Once again, to look at operational capacities, once again, to be able to assist in those areas where we're underserved. So there's a lot of good things in there. There's some things that, once again, may come forth through the budget once the legislature approves the budget. And we're hopeful that some of these initiatives will enhance our operations. The other thing too is for the agencies is just looking at the Bureau of EMS, the sustainability tag with the 25 initiatives. I think every agency should look at the initiatives that were adopted by the technical assistant group through New York State. There's a lot of good initiatives in there. There's a lot of things that will be starting probably this year and working their way through the next 3 to 4 years that will impact agencies in some cases significantly. So we really need to, once again, take a look at that. You can find it online. Once again, be familiar with it, especially our agency managers, because once again, they will probably be impacted the most with that. And that's pretty much all I have today. Thank you.
Thank you, Mr. Chairman. Any questions for Rensko? Yes.
I know talking to some of our cardiology colleagues, they're getting away from the STEMI kind of acronym, moving more to OMI, occlusive MI, which could be STEMI or non-STEMI. So I'm not sure down the line if that's coming down.
Well, we need to just make sure that whatever we do is consistent with the scope of practice, hospital training and education, and our protocols. So when there's an evolution in the protocols and an evolution in the way the pre-hospital providers taught, then we could begin to change nomenclature. I think it would be a little precocious if we did it sooner because we may get people lost in that mix. But that's good that you want to push, so I welcome you to come to the state and encourage you to propose that change. How's that?
That sounds good.
Okay. There you go. You step, yeah, you raise your hand. Careful what you're raising your hand for.
Albany is beautiful.
Yes. So moving on the agenda, we have EMS coordinator Don Hudson.
Pretty much everything's covered. Stay tuned for the state meetings next week. You know, particularly of interest to the region. I know the EMTCC discussion and sunset. Again, the 2027 date as proposed by Training and Education is being sent back to both medical standards and the CMAC, the state counterpart to REMAC, for their discussion and action. Those meetings have to take place on theoretically Wednesday morning.
Let's hope.
We'll see how that goes.
As of now, the meeting's on.
Quorum. As of right now, everything's status quo. So, which means snafu. And if you don't know what that means, see me afterwards.
Fantastic. Not to put you on the spot, but you know, ED committee liaison, Dana, do you have anything to share?
The only thing is I sent communication earlier today regarding an update from General Devices for Cambridge. If you didn't receive the update, please reach out to me. It was updated last week. So you should have received a notification on your screen to come to an update. If you didn't, I have to work for you.
Oh, thank you. That's I should have put that under the E-Bridge report too. Thank you. So you have to update, the providers have to update the software in their devices. The hospitals have to update the software on their machines. Medical control has to make sure all their machines are up to date. It's a security / improvement update that I think by the end of this month, which is today.
And then Dave, just once we pass the sign off at the hospital on intubations, then we'll just get that to you so you can get that out to all the ER, so they know about that. Yeah.
Just to be clear, because some questions have come in. There's no eBridge downtime related to this. It's literally just a patch.
Right, you just hit
Only 'cause
reboot
people-
and it reboots. It's a, yeah.
I was
it's-
on it. CHS is all over it. I did a CHS wide IT roundabout webinar yesterday because they thought they needed new computers and it's been handled. I know.
You could have said yes, you need
I-
new
yeah,
computers.
I-
You could have worked in
I
new
wanted them
Apple
to buy you
computers
one,
for
but
all
I
the
wanted to
directors.
prison, so there you go.
All right, so is there anything from the fire marshal's office? Think of, no, okay, all right, moving on, we're at unfinished business, so the e-bridge updates we sort of gave. The stats are put out every week in Don's report. The usage is going through the roof, which is phenomenal. E-bridge continues to grow and develop, so thank you. There was, again, the issue, we had a surge disaster where we reverted back to using the regular or the old-fashioned radio and telephone. That would have been a great opportunity to surge and test e-bridge, but you know, I'd rather no mistakes happen and the patients get cared for. We could surge and test later, so that's sort of what we're doing. E-bridge is sort of growing, and that was one of our little tests. I'm sorry? Oh, daughter, somebody say something. All right, and then, is there any other old business from the committee? Okay, so there was, the BLS IGEL stuff was mentioned in your report, so thank you. Yep. So under new business, we have, like a 3-for-1 from, Airway. Which is, did you want to bring up those motions? You want me to read them?
You can read it, that's fine.
Okay, all right, so the Airway Committee, Dr. Newbert's committee proposed a 3-for-1 motion to the changes to the policy manual. And it'll be voted on all in one part. The airway changes will be that all advanced airway attempts and placements must be documented on a regionally approved form via eBridge with confirmation by the ED physician. I wrote it shorthand, I need to. With notification to go out to the ED committee upon implementation. Part 2 is any ALS provider placing an advanced airway must remain with the
Any
patient.
provider, not ALS, because it could be
Any-
ALS that way.
Right, okay, so any provider. Thank you. Any provider placing an advanced airway must remain with the patient for the duration of the call, except for extenuating circumstances. And then all MFI will be reviewed by the committee. So basically, the airway committee is reviewing every airway procedure and attempt. So that's the first motion. So we could do roll call, or we could just do by all in favor of the physician members. Aye. Okay, anybody opposed? Anybody abstained? Okay, great, so that passes. Good job, Dave.
Thank you.
And then the second, I guess it'll be part of old business at this point. New Hyde Park is going to be adding a new medic to their RSI list. We'll have a second RSI medic in Nassau County once their medical director comes to the RSI committee. I was gonna put his name, but so we'll add that to the old business
We'll put that for next month.
for
Yeah,
next month.
correct.
And then the last thing is we need approval for I guess our two newest members who will be non-voting until a seat opens up. Dr. Stephen Mulbauer from St. Francis and Dr. Matthew from St. Joe's. So, sorry? Stefan, yeah. He's over there somewhere. Yeah, Dr. Morlidi. Okay, anybody want a second? Okay, Dr. Roy. And then all in favor? Anybody opposed? Anybody abstain? Great, welcome, guys. So we have 2 new members. That's great. So we have a full 20 members voting and then 2 non-voting members to the REMAC. Is there anything else for new business for the committee? Okay, there's one other motion that's in order.
Motion to adjourn.
Dr. Rowe, Dr. Newbert, okay. Thank you, everybody. Stay safe.
Thanks, everybody. Oh, okay, great. Now, I'll answer this.
My wife's
No worries. I got you. Yeah, you're welcome. Thanks. Okay. Sure. All right. Yeah, yeah. You want
I'm still at, oh, yeah, yeah, yeah.
got it.
Yeah, right. Nice.